Hello, and welcome to today's webinar, Prehabilitation, Optimizing Patients to Improve Outcomes. My name is Catherine Coons, and I'm a nurse practitioner at Penn Presbyterian Medical Center in the Division of Thoracic Surgery. Welcome you all for coming. I'm your moderator today. And first off, I'd like to introduce you to our panel. Next slide. First up is Dr. Clarissa Mathias. She is a medical oncologist, NOB Onco Clínicas and Hospital Santa Isabel. She's also the president of the Brazilian Society of Clinical Oncology and the chair of the IAC at ASCO. Also joining us today is Zoe Merchant. Zoe Merchant is a highly specialized occupational therapist and the program lead for the Greater Manchester Prehab for Cancer and Recovery Program, UK's first regional-wide rehab and prehab service for people affected by cancer. The service has had over 2,000 patients access it since its inception in April of 2019. So welcome, Ms. Merchant. And last we have Ms. Catherine Granger. She is an associate professor of physiotherapy at the University of Melbourne and the head of physiotherapy research at the Royal Melbourne Hospital in Australia. Her research program focuses on the role of exercise for patients with lung cancer. She was an author of inaugural Cochrane systematic review on the topic of preoperative exercise training for patients with lung cancer. So welcome. I look forward to hearing all of your presentations. And take care. Here are the disclosures. None of our planners, reviewers, or staff. There we go. An email will be sent to send you after the meeting with instructions on how to claim your CME credits. Polling questions will be used throughout the talk. Please select an answer when a polling pops up on your screen. Answers will be discussed as part of the talks. All questions are going to be answered through a Zoom Q&A function at the bottom of the screen. You can use this chat for other discussions, and we actually are going to have a Q&A session at the end after all three presentations are done, and you can enter your questions at any time during these presentations. And as I said, at the end of all three presentations, we will have a Q&A session. We are not going to be using the raise your hand function. Next slide. And so I'm going to hand it over now to Dr. Mathias.
So good morning, good afternoon, good evening to each one of you. First of all, I would like to thank ISLC for inviting me, and I'm actually on the board of ISLC. I have the honor of representing Latin America. I'm ending my term now. So I'm going to talk about the physiological benefits of rehabilitation, the importance of being fit for treatment and surgery. Next, please. And we're going to start with one polling question, number one. So Mr. G is a 65-year-old male diabetic and obese who is evaluated at a follow-up visit 3 months after completing 4 cycles of pemetrexed and cisplatin. And it was used to treat a stage 2A non-small cell lung cancer as an adjuvant therapy. He complains of peripheral neuropathy grade 2, and he wants to discuss adhering to a serious exercise program. He asks you what is the most likely mechanism that could help with these impairing side effects. And you list several mechanisms that can help him, except, so promote an anti-inflammatory state, improve muscle fiber recruitment, improve gait and balance, weight control, and decrease bone turnover. So now you can vote. Okay, so let's now talk about exercise. Guess I'll take over now. Zoe? Okay, so my mission today is really to convince you that our patients need to exercise. I guess, okay, let me try to see. Okay, so 1/3 of major impairment in daily activities due to their lung cancer. So patients with lung cancer are really physically impaired in a lot of cases. And there is persistent physical and psychological impairment. And most patients do not meet physical activity recommendations before or after treatment. The usual care does not normally include exercise training or pulmonary rehab, and it's going to be great to discuss that here today. So how can we incorporate exercise practices into patients' lives? And actually, I'm going to really show you data on if we can prevent cancer, improve surgical outcomes, and improve symptom management. So let's start by talking about cancer prevention of lung cancer. So can we prevent lung cancer with exercise? And there are actually 16 studies that examined physical activity and lung cancer risk. 12 cohort studies showed a pooled risk reduction of 23%. And 4 case control studies showed a pooled risk reduction of 38%. Physical activity actually does lead to a risk reduction in a meta-analysis of 11 studies comparing highest versus lower levels of leisure time physical activities, adjusting for smoking intensity, showed that a moderate intensity led to an OR of 0.87, and a vigorous intensity showed an OR of 0.7. So actually the relative risk comparing highest versus lowest levels of physical activities was protective in terms of lung cancer risk, if you look here. So there's actually a lot of data to discuss physical activities with our patients, even after they have lung cancer, or even in patients who are smoker and who are at risk. So the possible mechanistic models pathways are related to sex hormone productions, metabolic hormones, inflammation and adiposity, oxidative stress, DNA repair, xenobiotic enzyme systems, and immune function. And actually during exercise, particularly moderate and intense aerobic exercises, we have increase in T cell population, NK cell population, and neutrophil quantities. And actually, you do see an inverted J curve that optimizes the immune function in patients who exercise with moderate intensity physical activities. And probably the proposed role of physical activity and exercise is really the mobilization of polarization of tumor-associated macrophages to M1 phenotypes that do have anti-tumor activities. And when you don't exercise, you actually polarize them to M2 phenotype that supports tumor growth, local invasion, and metastasis. Prospective cohort studies do show association between cardiorespiratory fitness, lung cancer incidence, and cancer mortality in men, with maximal exercise testing of almost 5,000 men that were free from malignancy at baseline, and then at a pretty long follow-up of almost 13 years, 2.1% of the patients were diagnosed with lung cancer, and 79% of those died from cancer. Actually 4 years after the diagnosis, and CRF was independently associated with cancer outcomes, and this is also important to discuss with patients after being diagnosed. One might increase in categories of moderate and high CRF, showed a decrease in lung cancer incidence and decrease in lung cancer mortality. So actually individuals diagnosed with lung cancer and at moderate or high CRF categories at baseline exhibited longer survival times. So let's now move to improved surgical outcomes, and actually Catherine will discuss that in much more details with you. So I'm just gonna start the flavor of it. So actually pre-op exercise helps to the post-op complication rates in patients with lung cancer. We do have a systematic review published a few years ago that showed a decrease in complications, length of stay, and improvement in quality of life for those patients. So there is actually a decrease with an RR of 0.52, and the length of hospital stay decreased by almost 3 days. There's this ProLuca study that was also published a few years ago and actually did have a strong exercise program beforehand and with early intervention. And it was a small study with 40 patients, 124 patients were screened, and they were included and randomized into those 4 groups that I mentioned. And the post-op exercise completion was 73%. So the results show that early exercise program for patients was safe and feasible, and the fast track setup, this pre-op home-based exercise, was not feasible for these populations. So we really need to have a mindset change for the lung cancer patients. The early initiated post-op rehab reduces fatigue in patients with operable lung cancer. This was a randomized trial that showed this 2-arm control trial with early initiated post-op rehab or a control arm with late initiated exercise. The primary endpoint was really the change in maximum oxygen consumption from baseline to post-intervention 26 weeks following lung resection. And we do see here that we have a decrease in pulmonary complications and length of stay again from surgery. So we do need to sit down with your patients and have them take exercise as a prescription. Also, we do see improvement in symptom management, and that's when we're going to go back to Mr. G and see that there are lots of deleterious sequelae of treatment, and I mentioned some of them that are most common in lung cancer. So fatigue, deterioration function studies, function status, and muscle weakness. And we see here that in the cardiovascular system, the chemotherapy really decreases VO2 max, decreases exercise tolerance and hemoglobin. And with exercise adaptation, we can see an improvement in hemoglobin, decrease in blood pressure, increase in VO2 mass, and decrease in resting heart rate. In terms of respiratory, the chemotherapy and other treatments can, radiotherapy also, can really increase the work of breathing and dyspnea. And the lung cancer, the exercise training really causes a decrease in work of breathing. In terms of musculoskeletal, we can really lead to cachexia, decreased muscle strength, endurance, power, bone loss, arthralgia, and myalgia. And with exercise, we can really preserve muscle and muscular strength, improve bone turnover, and improve joint health. In terms of neurological, we do see, as in Mr. G, peripheral and central neuropathy, cognitive changes, and loss of coordination and balance problems. And we can really, with exercise, improve muscle recruitment and improve gait and balance. In terms of metabolic, we do see weight gain and dyslipidemia, and we can improve oxidative capacity and weight management. And finally, we do cause hyperinsulinemia and increased diabetes risk, especially with the use of steroids. And we can, with exercise, improve insulin sensitivity, and decreased cortisol and estrogens. So really, we can do a lot with exercises related to the chemotherapy. So hopefully I do have convinced you that we are able to improve our patients' lives by stimulating exercise and preventing cancer, improving symptom management and surgical outcomes. Thank you. And now I'll hand it over to Zoe Martin. Thank you.
Thank you, Clarissa. That was fantastic. Really great to listen to you. So as Clarissa said, I'm really it's a privilege to be with you today doing this presentation. I'm Zoe Merchant. I'm the programme lead for the Prehab for Cancer and Recovery programme in Greater Manchester, which is what I'm going to be talking to you about today. So next slide, please. So just to give you a little bit about my background, so I'm an occupational therapist and the majority of my clinical career has been based doing complex rehabilitation, mainly in the community with patients of a wide variety of different comorbidities and conditions. So actually neuro rehab has been one of my main focuses, but more recently, obviously, I've been leading on the prehabilitation and rehabilitation delivery in Greater Manchester, which I'm going to go on to speak about. Alongside me delivering this region-wide prehab service, I've got quite a brilliant MDT. So we've got Dr. John Moore, who's a consultant anaesthetist. He's our clinical lead. Myself as programme lead and as the allied health professional involved. We've got a primary care GP called Dr. Karen McEwen, who's a Macmillan GP. And then we've got an exercise specialist, Kirsty Rollinson-Groves, who leads the actual service, delivering the service for the patients. Next slide. So the polling question that I've put together for you is, which of the below would you believe to be the most critical to the successful implementation of a prehab programme in your local area? So is it A, skilled workforce already able to deliver the programme? B, stakeholder engagement, including from MDT members, healthcare managers, commissioners and other colleagues? C, co-production with people affected by cancer? Or D, a research network to support the evaluation of programme delivery? So if you can please choose which one you think it is. Brilliant. So actually the majority have gone for stakeholder engagement, which is actually the correct answer. I will take over control if that's okay. Great. So yes, I'm going to go on to speak about stakeholder engagement to some degree in the talk now, but all of these aspects are really important. But for me, I think the stakeholder engagement is the really key part when you're trying to do quite large scale prehab delivery. So hang on just 1 second. So I wanted to start by talking about the area of the United Kingdom of where we've been delivering prehab for cancer. So for those of you who are familiar with England, this is up the north up here, Greater Manchester. So it's a really large area. And unfortunately, we have quite a large number of patients who are from some of the most disadvantaged areas of the UK. So in terms of kind of health inequalities, we really do have a large number of patients who present late with advanced cancers, but also have poor diet, not great exercise, quite often are smokers and have some alcohol dependency, really high rates of this. So this is not only are we trying to deliver prehab to a whole region, but it's also being mindful of the difficulties that some of the patients who are going to be engaging in the service might be faced with. Oh, hang on a second. Oh no. Sorry, I'm just... Aubrey, can you please take back control? That's it, thank you. Next slide, thank you. So in Greater Manchester, we actually have what's called Devo Manc. So for the rest of the country, a lot of the decisions that are made within the National Health Service come from London. But actually we have a devolved health and care system, so that for the entirety of the population, all health and social care decisions are made by the Greater Manchester Health and Social Care Partnership. So we have a mayor who's Andy Burnham, who's supportive of the delivery of our service. And it's a really large area. We wish it was as small as it seems on the screen. It's a really big area. The population size is equivalent to, you know, coming up for like New Zealand or some of the other smaller countries in the world. So there's a lot of patients coming through, around 20,000 diagnosed with cancer each year. Next slide, please. So I won't go into too much detail about what prehabilitation is, because obviously Clarissa's already given a really brilliant instruction around exercise and the importance of exercise in cancer pathways. But it's just really, from our perspectives, part of the reasons for why funding was provided for our service was understanding that actually the physiological and psychological challenges of cancer treatment, and how we're really trying to reduce those side effects that patients are potentially going to experience going through their cancer pathways. Next slide, please. Also within the NHS, we have what's called the long-term plan. So for the whole of England, this is kind of the overarching strategy for the next 10 years. And within that, we've got what's called the personalised care model, which is really about how you make all healthcare provision to patients in England personalised and holistic to themselves. So within that, you've got the aim for optimal medical pathways, of which prehab and rehab really should be part of. And then also you've got this aim for people to have what's called supported self-management. So really how you empower people to engage in their healthcare provision as much as possible. Next slide, please. Also, we've got the levers within the literature and the evidence base, of which obviously Clarissa's already shown you some of the examples from studies that have been recently published. But this is a brilliant study from my perspective, because what it did is it compared patients and healthcare professionals in terms of their priorities for their cancer pathways and what their real priority was for treatment. And whilst the majority of healthcare professionals would always put survival and some of the very clinically based outcomes as the priority, most patients often say that their priorities are around energy levels, pain, sensation, their physical endurance and their ability to carry out daily routine. And that really is the crux of prehab and rehab for me, which is why it's been really helpful to have studies like this one completed. Next slide, please. There's also the recent systematic review, which was an international collaboration, which came out of the World Health Organization. And essentially what this was showing is that you've got some examples of best practice and evidence base around physical activity and exercise in oncology. However, what we do know is that a large percentage of cancer survivors really do require rehab, and there are small numbers of this being offered to patients. We also know from this systematic review that it's really important that any kind of prehab or rehab offer is multidimensional and has got an interdisciplinary approach. And that's what's going to provide the optimal model of care. Next slide, please. So within the United Kingdom, we've had the Macmillan Prehab guidance, which was launched in 2019. This was actually an international approach where we used a Delphi process, and I was involved in this alongside colleagues from locally and nationally, but also international colleagues as well, where we came together to synthesize all the existing evidence around prehab and provide some really clear guidance around what should be done for prehab for people who are affected by cancer, including giving that very clear guidance that people should be exercising. Next slide, please. And we were able to use some examples from patients in Greater Manchester within this documentation. So just giving some vignettes and also just showing some of the kind of examples of the types of exercises we do in the local gyms with our patients. Next slide, please. So within Greater Manchester, we already have what's called the Enhanced Recovery After Surgery Plus scheme. So within all the different major hospitals, of which there are 10 in Greater Manchester, we've got surgery schools. So patients and their family members are invited to come to an education session in the week or so before their surgery. But what we were finding in these surgery schools is that actually it's not enough to just give the advice. You really do need to provide a service and a program for people to engage with, especially when they've just had that very scary diagnosis of cancer. They really do need their hands to be held through the process. Next slide, please. So building on that, GM Cancer, which is the organisation I work for, which is a cancer alliance, came together with GM Active, which is all the local leisure organisations in the area in Greater Manchester, to deliver the Prehab for Cancer service. And just to be clear, we're not trying to turn the gentleman on the left into the gentleman on the right. What we know is the gentleman on the left has probably led quite a sedentary lifestyle in advance of his diagnosis of cancer, and is really going to benefit from quite intensive exercise in the run up to his lung cancer treatment. Whereas the gentleman on the right, although he might be physically prehabbed, he might deteriorate through neoadjuvant chemotherapy, but also he's going to benefit from the nutritional and the psychological elements of our programme. Next slide, please. So within Greater Manchester, we have different pathway boards for all the different tumour types. So this is all the different MDT members, consultants, surgeons, oncologists coming together on a regular basis to try and drive improvement for within the NHS for those tumour types. So we already had a lung pathway board, which is chaired by Matt Everson, who's a respiratory physician. And we were able to use that to create a lung subgroup and subgroups for the other tumour sites that we cover in our programme, which is colorectal and OG, and bring all the different stakeholders together to really design this service and implement this service successfully. We also were able then to feed back up into the Health and Social Care Partnership, which I mentioned earlier. Next slide, please. And our aim was really to embed prehab and rehab as part of our cancer treatment pathways within the NHS. So this is an example of one of the pathways, which is the lung cancer pathway. And for lung cancer, it's not just the surgical patients. We actually offer it to anyone who's experiencing any kind of curative intent, whether that's radiotherapy, chemotherapy, or surgery. So any of those patients at the point of diagnosis can be referred into the Prehab for Cancer service via a single point of access, which is an online form. And then they're contacted within a couple of days of that referral being received. So we only have the time available within the pathway to do that intensive prehab with them, which might only be 2 or 3 weeks. So we really have very quick turnaround times to make sure that we can see patients really quickly and do as much prehab with them as possible. And as I said, we've got 10 different major hospitals who all refer into the service. Next slide, please. We've done a lot of co-production and user involvement. So we did a focus group right at the beginning of the project. And what we found from that with speaking to patients who've affected by cancer is that they found prehab to be very acceptable and not burdensome, but they really needed their oncologists and their surgeons to be the ones who advocated prehab and reassured them about the safety of prehab. And also that the rehab is really important as well, because they often feel that they drop off a conveyor belt at the end of coming out of hospital. So it's making sure that whatever programme we designed, there was provision after someone was discharged and not just focusing on the prehab side. Next slide, please. We created a leaflet for patients and family members, which we co-produced with patients. And this was to really reassure people. Often it can be the family members who are the barrier to people engaging in exercise because their assumption is that it's not safe to do so. And so this was to really reassure people and to set the expectations before people joined the service. Next slide, please. And we've actually been cited in this recent literature publication around behavioural science within Prehabilitation, because basically saying how important it is to involve patients in the design and delivery of prehab for effective service design, but also to encourage really high uptake. Next slide, please. So it's really, really important to note that for prehab to be effective, it's not just about one profession. For us, it's about involving all the different interdisciplinary team members. So whilst we have exercise specialists who are the ones who are delivering our Prehab for Cancer service, we rely heavily on all the different MDT members to be involved and to escalate any issues or concerns to. Next slide, please. Here are some of the exercise professionals involved in the delivery of our region-wide service. Next slide, please. They all had level 4 cancer rehab qualifications already, but what we have done is a lot of upskilling with these exercise specialists. So we've used what's called the stepped care model, which is around psychological provision and training and competence. So we actually made sure that they were able to do effective communication and empathy and really noticing distress. So they all had that competency before they started to see patients. And then we also do reflective sessions with the staff involved in the service every couple of months with a psychologist pod there. And we do lots of regular CPD sessions as well, trying to really upskill the exercise professionals involved in the delivery of the service. Next slide, please. There's a national exercise workforce collaboration going on within the UK, which has very much come out of the Macmillan Prehab guidance. And this is really looking at the different exercise professionals that are involved and what kind of registration and competence we want them to have. But it's also being aware of allied health professionals and understanding the potential extra competencies and trainings that's required, for example, for physiotherapists, occupational therapists and others. Next slide, please. So just going back to what we're delivering in Greater Manchester. So these are all the different leisure organisations in our in the whole of the region. So all of them are working together, and we deliver the service within 87 different leisure facilities, local leisure facilities that are publicly owned. So basically gyms and swimming pools, environments that are just down the road from the patients where they live. Next slide, please. And what we know from all the kind of stakeholder engagement and for the research we've done is that we really wanted to take the path of least resistance. So we know the moment that we ask patients to travel a far distance to come and get involved in prehab, that we were definitely going to lose the uptake that we wanted. So we made sure that patients only have to travel less than 5 miles or less than half an hour. But normally it's literally that they're going to their local leisure centre, which is down the road in the suburban area that they might live in. Next slide, please. What we do is we have a range of assessment clinics, and that's at different points in the cancer pathway. So we can make sure that we're delivering personalised pre-habilitation and rehabilitation, but also so we can actually evaluate the delivery of the service and make sure that patients are actually making the improvements that we would expect. So these are all the different quality of life and physiological assessments that we do with patients at the different time points. Next slide, please. And what we've done is we've actually used the universal targeted model, which some of you might be aware of. So it's that idea that not all patients need the same provision. So the universal offer is very much for the patients who are able to be quite independent and come along to the gyms and follow an exercise prescription with that occasional check-in from the exercise professionals. Whereas the targeted offer that we provide is 3 times a week, supervised sessions in small groups, in the local leisure centres, and that's aimed at the gentleman I showed you on the left before. So those that come into the programme probably having led quite sedentary lifestyles and needing a lot of support and intervention to support them to engage in exercise. Next slide, please. So here's an example of the exercise programmes that we deliver. So depending on the assessments in the beginning, we really do, we're either doing re-hit or we're doing continuous exercise. And if somebody's going through chemotherapy and radiotherapy, then we really do drop down what we're doing and we monitor it quite carefully, because obviously we don't want to introduce any risk or any potential toxicities or anything. So those patients do continue to do the prehab exercises they've been prescribed. However, obviously for the surgical patients, they have a break for their surgery, a short break afterwards, and then they come back and everyone gets 12 weeks of rehab back at their local leisure centres before they're discharged from the service. Next slide, please. We also have our website, prehabforcancer.co.uk, which has got lots of videos of exercises, and it's got descriptions, and it's got nutritional and wellbeing information. And we've used a lot of patients to support us because we recognise that for lots of older patients, it can be quite off-putting going onto a website and seeing quite young people wearing lycra doing exercises. So that's available for anyone who wants to access that. Next slide, please. So these are some of the figures from the service. We've had nearly 2,000 patients referred in the first couple of years, referrals from all the different hospitals in Greater Manchester. We've got an 80% participation rate from referral, which has actually increased during COVID. And from the first appointment that patients engage in, we've got a 94% uptake rate. All patients access the service locally to where they live. And we've had over 1,000 patients access our remote service during the pandemic. Next slide, please. And we've had a really high number of older patients access the service. So I think sometimes there's a perception that older patients won't be able to engage, whereas actually this shows you that we have really high numbers of people in their 70s and 80s engaging in the service. Next slide, please. Here's some of the data that's come from our patient reported outcomes. I mean, this is very early data, and we did need to do a lot of further evaluation and statistical analysis. But so far, we're showing absolutely improvements in terms of people's cardiovascular fitness and in terms of their nutrition. Next slide, please. So this is just an example from the lung pathway. So you really can see from this that we are really making some vast improvements pre-operatively, and then actually when people are in their rehab phase as well, which is logically shows that you're going to have improvements on clinical outcomes as well. Next slide, please. So we're going through a full evaluation at the moment, and what we're trying to do is really show value for money. We have actually had recurrent funded awarded, so the service will be continuing for the years to come. However, we do really need to show that we're providing value for money and that the service almost pays for itself, which we absolutely think we'll be able to demonstrate. So this is the approach we're taking, using all the hospital outcomes and connecting that with our data set to show improvements, and using legacy cohorts to show a comparison. Next slide, please. We've also been doing an acceptability study with the University of Manchester. So we actually did semi-structured interviews with quite a few of our participants. And what that showed was that prehab's absolutely acceptable. Transport is a major consideration. So it really is about how you make it local for people. And that actually patients really benefited from all the psychosocial support they've received from the Prehab for Cancer team throughout their cancer pathway. Next slide, please. So just in terms of our next steps, we really want to think about some of the much more complex and frail and older patients, and understanding that we need to involve lots of different specialist team members to be able to deliver that kind of top bit of the triangle. We're looking a lot at digital and what we can do in a post-COVID era. We're looking at the research in terms of mechanisms of prehab and rehab delivery. And then also we're looking at how we can extend our current offer to other tumour sites within Greater Manchester as well. Next slide, please. So here's just acknowledgement of all the different people that have been involved in the design and delivery of the Prehab for Cancer service. And then finally, the next slide. This is just some comments from some of the patients who've engaged. We've got some brilliant videos on our website of people who've really benefited from engaging, but this was from some focus groups we've done more recently, really showing how beneficial patients have found it. So I'll now hand over to Catherine.
Thank you very much, Zoe, for a fantastic presentation about your service. And thank you for the invitation to speak today on specifically on the topic of the exercise component of prehabilitation for patients with lung cancer. Next slide, please. So I'd like to start with our final polling question for today. Susan is a 70-year-old female who was recently diagnosed with lung cancer. She is, her presenting symptoms were fatigue, weight loss and a dry cough, and she's now scheduled to undergo surgery in 3 weeks' time. She's a past smoker and she's currently active in a small way in terms of doing gardening at home, but she does not participate in any regular form of exercise or physical activity. So at this point, what would be the most ideal exercise prescription or exercise treatment for Susan before surgery? A, to do nothing and not change her exercise behaviour until after surgery. B, to start a combined aerobic and resistance exercise program with a goal of building towards 30 minutes of moderate intensity walking or cycling and 2 sessions of strength or resistance training per week. C, to commence a resistance only exercise program. Or D, to recommend Susan stop gardening and rest as much as she can before surgery. Please vote on your answer now. Excellent, 98%. So this group is a group in favour of exercise. So at this point, we would recommend Susan be linked in with some exercise professionals or health professionals and start a supervised exercise program. And I'll talk today about the rationale for exercise and also the evidence from the literature in terms of the benefits of exercise. So it's well known to this audience that lung cancer is associated with significant morbidity. Some examples to show this to you, the data on the screen represent patients diagnosed with lung cancer following these patients from time of diagnosis before surgery, across till after surgery and 6 months after diagnosis. And as you can see on the screen here, when you look at markers of functional exercise capacity or markers of peripheral muscle strength, we see a steady decline in these outcomes over time. The other thing you'll notice here on screen is the red dotted line above both of the figures represents the predicted performance of this group of patients based on their age. And what we know is people with lung cancer going into surgery are already at risk with poorer levels of exercise capacity and poorer muscle strength, as well as many other outcomes compared to their age-matched peers. So this is certainly a vulnerable group we're working with before they even have surgery. We also know, as Clarissa highlighted at the beginning of our webinar today, most people with lung cancer do not meet the physical activity recommendations. Some of the research we've done looking at this to date shows that only approximately 40% of people with lung cancer at time of diagnosis meet the recommended physical activity guidelines. This drops significantly after treatment and over time. And then one of the groups that is most vulnerable, in fact, are people with inoperable lung cancer. And I know that's not the focus of the webinar today, but to highlight that's a particularly inactive group. And some of our more recent research has shown that on average, a group of people with inoperable lung cancer only walk about 3,000 steps per day, which shows this is overall a very inactive group. We also know, as our webinar has highlighted and as my talk today will highlight, that we have very good data showing that physical activity and exercise training is effective at improving many outcomes for our patients. But unfortunately, exercise programs are very rare, and the program that Zoe has highlighted to you is an outstanding example of a prehabilitation program and a very successful service in the United Kingdom. But generally, these programs are rare and infrequent around the world, and we certainly have a long way to go to improve access for our patients to receive this intervention. So there are many times when we could intervene with exercise training, and now I'm going to really focus down on the exercise component of prehab. If we look across the lung cancer treatment pathway, we have evidence and good data to support exercise at all of these time points, but today we're really focusing on pre-surgery. The rationale, I'd like to begin by talking actually about the rationale of exercise and why we might be prescribing exercise at this time point. We have in lung cancer an opportunistic waiting time where we have a number of days to weeks. It's very short depending on where you're based. Often it is less than a month, but we have this opportunistic time where a patient may be being worked up for surgery, they may be going through diagnostic procedures, there may just be a waiting list and a time to get into surgery, and we have this time where potentially we could intervene and with potentially powerful outcomes. Now, if we don't intervene with anything at this time point, we would assume exercise capacity in this period of waiting time remains stable. There's a big insult to exercise capacity or VO2 peak at the time of surgery, and then slowly a recovery over time again without intervening. Now, we hope that many patients without intervening with exercise rehabilitation would recover back to baseline levels of exercise capacity. And certainly there's a cohort of people that do. But some of our high quality research coming out of some of the best clinical trials we have in this area are actually showing that the control group or the usual care group are not recovering back to baseline even after surgery. So therefore, the rationale of intervening before surgery is to improve exercise capacity levels, identify and target any specific impairments, theoretically, the insult of surgery is the same magnitude, but then if we intervene in the post-op period or without that, we're on a different trajectory recovery to help that patient recover back beyond baseline, ideally, to improve their health and reduce incidence of future impairments. So specifically, the rationale of exercise at this time point is to target and improve functional exercise capacity. And that's the outcome that we're really interested in looking at how it can relate to surgical outcomes. What we know from evidence now is that functional exercise capacity is an independent predictor of post-operative pulmonary complications for people with lung cancer. We also know, and it will be well known to this audience, that there's good data to show the relationship with lower levels of exercise capacity or VO2 peak, and they're related to an increased risk of complications, and also, as Clarissa's highlighted, worse long-term survival. We also understand in this population that post-operative pulmonary complications are associated with a number of adverse outcomes, increased ICU admissions, longer hospital length of stay, readmissions, and also from data from Paul Agostini's group in the UK showing it's associated with early and late mortality in lung cancer. So therefore, by intervening before surgery with prehabilitation and targeting exercise capacity, we're aiming to improve VO2 peak and therefore hope that this translates to improvements in a reduction in complications and improvement in other post-operative outcomes. So I'd like to go on and share with you the evidence supporting that theoretical rationale of exercise. Now, a number of years ago, Associate Professor Vin Cavalieri and myself published this Cochrane review on preoperative exercise training in lung cancer. And as many of you will know, if you're familiar with Cochrane reviews, they get regularly updated. I'm excited to tell you that we're currently updating it right as we speak now. And hopefully, if we work hard enough, we'll have that published this year, if not early next year. So I'll highlight a little bit of what we know. We're in the early stages of the update as I go through these slides, but I'm also going to draw upon some other excellent publications that have come out recently. So my initial preliminary search just late last year showed a huge amount of research in this area in lung cancer. And the figure here, there's small numbers, but just to highlight how much the research has grown. If you look back from the early 2000s, there's only a small number of studies coming up on Medline compared to, 2018, 2019, 2020, we're getting lots more hits. So there's a lot of research, particularly over the last decade, that has really focused on this area, which is exciting for us because we need stronger data to improve access. And as I mentioned, there's been some outstanding systematic reviews published very recently in the last year or two summarising this topic. So that if you're interested specifically in this, please go and have a look at some of these papers in more detail. But I'll highlight some key findings now. We know there are approximately 15 randomised controlled trials conducted in this area of our highest randomised controlled trial evidence. These are ones specifically looking at exercise training in the preoperative setting for people with lung cancer. These studies are very small. The sample sizes range only from 19 to 151 patients. So they're very small studies and most commonly been conducted in the United States, China, or Europe. The preoperative exercise programs range a little bit in the studies conducted so far, but generally, I've summarised the interventions generally so you get an idea of what they look like. They range in length from 5 days to 8 weeks, and that's really dependent on the time someone is waiting before surgery and the time we have to intervene. They're generally conducted in a supervised setting, supervised by health professionals, normally in an inpatient or outpatient setting. And often these are individual programs for one-on-one with a therapist or a patient, or a group setting. And they very frequently occur from 3 times a day for the programs that are being conducted for inpatients, compared to 5 times a week for the outpatient program. And for those of you that work in exercise programs with other patient groups, you'll notice this is a very intensive program. We're exercising with patients very frequently in a short period of time. So we have a very short period of time to actually intervene. And the programs generally, as highlighted in my question at the start, focus on certainly aerobic exercise training. That's critical. We need to focus on aerobic training to improve exercise capacity, but more often than not include resistance training or strength training as well, sometimes inspiratory muscle training, and they're focused on moderate to high intensity exercise. We have some excellent outcomes of early data. And I say it's early because we still have only a small number of trials. These meta-analyses are from some of the recently published systematic reviews. I'm hoping our new Cochrane review will pull together all of the data and we'll be able to share that with you as soon as it's ready. But so far, we've got some promising early signs. You can see here on the screen, we've got improvements in the 6-minute walk test and VO2 peak, both measures of exercise capacity immediately post the programs. Reduction in dyspnea immediately post-exercise programs. And then after surgery, we are seeing reductions in the rate of post-operative pulmonary complications and a reduction in the length of hospital stay. So there are small numbers that you'll see in the meta-analyses generally. And as I highlighted before, a small number of participants in the trials, but these are really, really promising early signs of the data we have so far. One issue that we don't understand well yet in prehab and lung cancer is what are the long-term outcomes. The evidence I've shown you so far really looks at short-term outcomes before and after a program change and then immediately after surgery. There's been one study from the group from Licker and colleagues who conducted an outstanding randomized control trial in this area and published a number of follow-on papers from their trial. And this is one example, or really to my knowledge, the only example we have of a group following up to 12 months after a prehab program. And they didn't find any difference in groups at 12 months in terms of survival, respiratory function, or exercise capacity. And by that point at 12 months, despite having a positive finding of the prehab program early on, both groups, the usual care and prehab group, had a similar decline in exercise capacity. One of the other big questions for our field in terms of implementation is actually the cost effectiveness of these programs if we're looking at implementing them into practice. Again, we don't have much data on this. Some of the trials, and this one here is an example from a lovely trial in China, looked at cost effectiveness as a secondary outcome in a small study of 68 patients. They reported in their intervention they had saved a hospital length of stay, a median of 5 days difference between groups, and a reduction in total drug and material costs. And you can see the figures on the screen. The median intervention cost US just over $7,000, whereas the control was just over US for $8,000. So we certainly need stronger data and trials looking at primarily at cost effectiveness, but again, it's a good early sign. And this is a trial that I'd like to draw your attention to that is currently in progress that I think will really help answer some of these questions. It's an excellent trial that's providing a multimodal prehabilitation program to moderate to high-risk patients undergoing lung cancer surgery. The primary outcome is change in hospital length of stay. It's involving an excellent multidisciplinary prehabilitation program beyond just exercise, which I've talked about, and we'll be looking at cost effectiveness. So I really look forward to hearing the results of that trial when they become available. One of the other big questions for our field is actually what is the optimal type of exercise training? This is still unclear. As I mentioned, most programs include an aerobic exercise component. That seems essential. But then there are other trials that including things like inspiratory muscle training and resistance training and balance training. What we know so far is inspiratory muscle training alone improves some outcomes, but it's not the best combination, whereas aerobic exercise in combination of inspiratory muscle training appears to be superior. But we have a lot of questions in terms of designing the ideal program, and there are many of us doing work in this area at the moment to help address that. And then finally, I just thought I'd pose to you some future research questions. Very recently, Vin Cavalieri and myself wrote this editorial for Respirology, and we proposed 7 questions to the field looking at exercise as part of lung cancer therapy. And 3 of them I think are pertinent for us to think today. What is the cost effectiveness of these programs? What is the evidence for delivering it via telerehabilitation? And what is the optimal length of programs? And these are going to help us with implementation in the future. So in summary, preoperative exercise training in 2020, what we know from the evidence, it's safe and it's acceptable. There are certainly questions around feasibility, and I haven't had time to go into this today, but Zoe has given you an outstanding example of a feasible program, but many of the signals we're getting from the evidence, and certainly from my experience in Australia, is it's often not always feasible. We know it improves exercise capacity and a number of other outcomes. The problem so far is we have small sample sizes in studies. Generally, they're low quality and we need longer term outcomes. But clinically, we currently recommend, based on all of the evidence we have so far, that exercise training as part of a prehab program be considered for people awaiting surgery. We do not recommend that surgery is delayed for someone already fit for surgery, but we certainly need more research in this area. So I thank you very much for your time and look forward to questions. Thank you.
Oh, hi, thank you. They were all wonderful talks. We're now going to open up the Q&A session, which you'll find down at the bottom of your screen. And also the slides for these talks will be available to anyone that would like to look at them and download them at a later date. I'm going to look at some of the questions we have here. We have actually a question for Zoe asking about what percentage of the patients participate in your wonderful program.
I think that's actually been covered already. I think the same person then realised, because I did talk about it in the presentation. But
Okay.
Yeah, but just to reiterate, actually, I didn't actually say it, but during COVID, that has actually gone up, because I think because we've been doing it in a way that people really can access the service. Also, I think because healthcare professionals have been redeployed into other areas, and so they've really relied on the service for that kind of support going through the COVID pandemic.
I have a question for the whole panel. So as far as costs, in the United States, we don't have a lot of pre-rehab programs. For patients that really are having a hard time, we can get them into rehab before their surgery, but it usually means we're going to have to delay their surgery. And it's really difficult to get them into rehab before their surgery. How are these programs being paid for? Is it in the UK? Do you have, does the government, Zoe, does the government pay for these programs?
Yeah, sorry. So yeah, the program that we're delivering is via the NHS. So it's free at the point of contact, as all kind of healthcare provision is within the UK. And it's not just ours in Greater Manchester. There are other prehab programs that are being delivered in other parts of the country. But I think it really does vary how on what scale and for what types of cancer treatment that they're available for. Yeah.
Okay. And how about in Australia? Are there programs available that are paid for, or?
Very rarely. It's very similar to the United States at the moment for us, unfortunately. There are a small number of government funded programs, but they're very rare.
Yes. And in Brazil?
So here we have the same problem, actually, which is like we need to discuss with the payers, because it does decrease complications and length of stay. So they really need to be implemented.
I think we just need more studies to show that it will be more cost effective, and then maybe everyone will be on board. But yes, it is a problem. I agree. There's another question here from Jane. It says, our outpatient rehab is always busy and it takes many days to obtain an appointment. Thoracic surgeries are scheduled quickly. How do you manage to get in the appointments in before surgery and avoid delays? Does not seem feasible in our area, though we totally agree it would be incredibly beneficial. So I guess the same kind of question that we all just kind of spoke on. And then there's another question here about, have any of you done any post-surgery review for scar tissue manipulation? I don't know, is that something they do in I don't know, I think that's a.
No, and nowadays the scars are really so small.
Especially the robotic scars, they're tiny. Yes.
Thank God, because in the past this was a major problem.
Yes, it was, but not so much anymore. Especially. Go ahead.
Oh no, sorry. Carry on. Sorry. I was just going to answer the feasibility question that you asked just before. So I was just going to say that we do get that often. People say, how are you able to fit it in? And I think that's why it's so important to really look at the cancer pathway and make sure that the referral happens as quickly as possible. But one thing I would say is that a lot of our lung respiratory physicians were trying to refer patients before formal diagnosis, trying to build in more time in the pathway, but that actually caused a lot of problems because at that time patients don't know if they've got the diagnosis or not, so they're very preoccupied with whether or not they actually have cancer, and it really started them off on the wrong foot coming into the service. So we've actually had to work very closely with the clinicians that we really do need to wait until patients have got that confirmation of cancer, and that seems to be the optimal time, but then you do need to have the infrastructure and the mechanism so that you can really maximize the sessions in between that point and then when the cancer surgery is being delivered.
We have a question by Pippa who says, do any of you find there is a difference in the prehab approach depending on treatment plans, chemotherapy versus surgery as their treatment plan? Are they treated differently in the way you approach their prehabilitation?
From my experience, no, probably the only difference is the time that you have, a little bit like Zoe was discussing. If you know you only have days or weeks, you'll target it a little bit more intensively. But in terms of the actual intervention, no, the goals are the same before treatment.
Yeah, and I was just going to add, so we do actually continue the prehab offer to people during their treatment, like I said in the talk, but I think we're really cautious in terms of especially people going through radiotherapy when they're literally going for, sessions every day for 6 weeks. We really do make sure that we drop down and we understand in terms of fatigue, etc., really trying to be balancing between what's going to be beneficial versus what's going to cause problems for the patient.
And then lastly, there is a question about during COVID, to Zoe, how did your service adapt during that time, and specifically regarding healthcare? So yeah, that's a question too. So did they close the gyms down and everything? And did you find the patients were able to keep up their exercise home by themselves, or?
Yeah, so basically we had to turn the service in 2 days from being one in the gyms to one that's like this via telephones and videos. But actually what we did do is we set up group exercise timetables so that people could do it, because really patients really wanted to be part of a group with other people. And in the kind of 9 months we did that, we had about 1,000 attendances of those exercise timetables. So we just, everything's been moved to telephone and video. And like I say, I think it's really has maintained uptake. But I think Catherine's research question about the evidence and of the actual outcomes that come with tele-rehab versus doing it face-to-face is so key, because in terms of informed consent, I really want to be able to say to patients, it's actually better for you to come and do it face to face, and we know this and we've got the evidence to show that, because at the moment I think we can't say hand on heart whether actually what we deliver in someone's home is the same as what they get in the gym environment. So I think that's a really important question from a research perspective.
Okay, well, it looks like that's all the time we have. I want to thank all of our speakers. They did a wonderful job. I'd like everyone thank you everyone for participating. And again, the slides will be available. Your CMEs will be coming to you. How to get your CMEs via an email will be sent to you. And again, thank you everyone for coming.
Thank you. And thank you, Aubrey. You did a great job.
Thank you.
Thank you.